acetylcholine will decrease the cholinergic supply. So anticholinesterases will be something which will enhance the cholinergic supply by prolonging the duration of action of acetylcholine. Okay, so therefore they are the indirectly acting cholinomimetic drugs. So we are talking about the cholinesterase inhibitors, or also known as anticholinesterases. Okay, so anticholinesterases are the agents that inhibit the acetylcholinesterase present in the synaptic regions. Hence, they prolong the existence of acetylcholine released from the nerve endings. These are either esters of carbamic acid or derivatives of phosphoric acid. You have to remember they could be either esters of carbamic acid or derivatives of phosphoric acid. There are of two types. They could be reversible or irreversible. See, reversible things are always better because you can put them to use, because if their action goes in excess, you can control them. But irreversible goes out of control. All right. Just to revise, they could be either derivatives of carbamic acid or phosphoric acid, or maybe something related to carbamic acid. They could be reversible, they could be irreversible. Let's talk about their classification a little bit. Now, reversible anticholinesterases. They include neostigmine, physostigmine, pyridostigmine, rivastigmine. These are all carbamates. While edrophonium, donepezil, galantamine and acridine or tacrine are related to carbamates, but they are non-carbamates. Okay, so they could be reversible, irreversible, they could be carbamates, they could be non-carbamates. Then there is another group of anticholinesterases or cholinesterase inhibitors which are irreversible. Okay, irreversible include carbamate insecticides or organophosphorus compounds. They are mainly organophosphorus, but some of them are also carbamate. Okay, organophosphorus include pesticides, like parathion, malathion, diazonin, fluorpyrifos. These are all pesticides. Then you have nerve gases which were used in chemical warfare: tabun, sarin, soman, and others like ecothiopate. Ecothiopate is very different. How it is different, we will talk about that. Okay. Then you have carbamate insecticides, which include carbaryl, propoxur, and aldicard. I'll repeat. They could be organophosphorus compounds or carbamate insecticides. Carbamates include carbaryl, propoxur, aldicard. Organophosphorus includes pesticides like parathion, malathion, nerve gases like tabun, sarin, and ecothiopate. So this is in short the classification of cholinesterase inhibitors. Now what do they do? See, cholinesterase inhibitors have to behave like acetylcholine because they are acting on the site where acetylcholine was binding on to cholinesterase, that is, okay. Acetylcholine was binding to cholinesterases and was getting hydrolyzed or broken. When something attaches to these cholinesters and therefore prevent the action of acetylcholine binding onto that site, will therefore indirectly enhance the cholinergic transmission. So acetylcholinesterase is an enzyme which has an anionic and esteratic site. You know, cation is a positive ion, anion is a negative ion. So acetylcholinesterase has got two types of sites: anionic site and an esteric site. Acetylcholine involves the binding to positively charged N+ of acetylcholine to the anionic site. So the positive charged acetylcholine has a positively charged nitrogen ion N plus. This positive will get attached to the negative or the anionic site of the choline esters. Acetylation of serine will happen and leading to acetylated enzyme. See, I'm telling you what acetylcholine does to the choline esters. It will bind to the enzyme acetylcholinesterases. This is the ester, this will bind to the esterases at the anionic site because of its positive ion, nitrogen positive ion, getting attracted to the anionic site. The acetylated enzyme reacts with the water. The acetylated enzyme will then react. First of all, the enzyme will get acetylated. How will it get inactivated? Once it gets acetylated, it reacts with water to produce acetic acid and free enzyme within milliseconds. So it will attach, water will attach to the acetylated enzyme and produce acetic acid and choline. And the enzyme, that is cholinesterase, will be freed. See, cholinesterase with acetylcholine will not remain bound forever. All it has to do is, within few milliseconds, inactivate acetylcholine, and inactivation of acetylcholine will be by binding of the acetylcholine to the anionic site, and then water coming and hydrolyzing this acetylated enzyme, releasing acetic acid and choline from there and freeing the enzyme cholinesterase. Okay. Now this reversible acetylcholinesterase combined with the cholinesterases and carbamylated combined enzyme is slow to hydrolyze within 30 minutes. See, acetylcholine was hydrolyzed within few milliseconds. When we are talking of reversible anticholinesterases, they will carbamylate and they will get detached in 30 minutes. While something like Edrophonium, which is also a non-carbamylated anticholinesterase, it has shorter duration of action. It will attach and detach within 10 minutes. Okay. Otherwise, it approximately the reversible anticholinesterases take about 30 minutes to produce their action. Now, this was about the reversible anticholinesterases. Now, let's talk about the irreversible anticholinesterases. These are, as I told you, mainly the organophosphorus compounds. So, acetylcholinesterase will bind to organophosphorus compounds. And this binding, as you understand, is irreversible. Acetylcholinesterase will be phosphorylated. And the non-phosphorylated metabolite binds at the esteric site by the covalent bond. If you remember your chemistry, covalent is a strong bond to break. So, acetylcholinesterase is phosphorylated. When water attaches to acetylcholinesterase plus phosphorylated derivative. But the hydrolysis of acetylcholinesterase along with being phosphorylated is extremely slow. Therefore, we are calling it irreversible. Phosphorylated enzyme is considered to be irreversibly inhibited. In this group of organophosphorus compounds, ecothiophate is an exception as its nitrogen binds to the anionic site and causes slow hydrolysis. So ecothiophate is the only organophosphorus compound which is non-polar. The rest of all of them are polar, and ecothiophate will bind to the acetylcholinesterases by some weak bond at the anionic site, and hence it will be hydrolyzed slowly. But this is for the information of everybody, all the other organophosphorus compounds are polar and they are irreversibly attached. Now, you will also come across this term known as aging of anticholinesterases. Why do we call that? What do we understand by aging? So when the organophosphorus compound attaches itself to the acetylcholine esters, its esterases, it becomes phosphorylated. You know that? And you also know that this phosphorylated enzyme is difficult to detach, even by hydrolysis. Okay? Why? Because phosphorylated enzyme undergoes aging by the loss of one or more alkyl groups and becomes totally resistant to hydrolysis. No reactivation of enzyme is possible, and this can happen in 1 to 2 hours. Why do we need to know this phenomena of aging of anticholinesterase? Now you know that anticholinesterases. Cholinesterase will break. Anticholinesterases get aged. That means organophosphorus compound will come and attach itself to the cholinesterases, acetylcholinesterases, and phosphorylate. And they become difficult to detach. Why? Because after phosphorylation, there is a loss of a couple of alkyl groups that makes this very resistant to hydrolysis. Why do we need to know that? Because organophosphorus compounds are important pesticides, and pesticide poisonings are also extremely common as homicidal or suicidal or for maybe accidental poisoning. And time factor is extremely important. If one is not able to manage it soon, the cholinesterase will become lose alkyl groups and become the phenomenon of aging will set in. And if the phenomenon of aging will set in, it will be very difficult to manage the patient by antidotes or by other management techniques. So therefore, the treatment strategy has to be adopted as soon as possible, otherwise aging of anticholinesterase will happen. Therefore, you need to know this phenomenon. Now, enzyme inhibition by these agents can be reversed by cholinesterase reactivation. One thing is cholinesterases, other thing is cholinesterase inhibitors. Now the third thing is cholinesterase reactivators. They are examples: pyridoxine, administered before the aging of acetylcholinesterase has occurred. Inhibition by the agents that undergo rapid aging is not reversed. I hope you can understand this phenomenon, that science has developed some cholinesterase reactivators because poisoning can happen by organophosphorus compounds. Reactivators will reactivate cholinesterases and the excessive cholinergic transmission, which can have problems, can be dealt with. But this has to happen very fast so that aging of cholinesterases does not happen. And inhibition by these agents that undergo rapid aging cannot be reversed. If some organophosphorus compounds undergo very rapid aging, then in that case, you cannot treat such patients. They will eventually die because of cholinergic excess. Now, the pharmacological properties of cholinesterase inhibitors. What we have talked till now is classification of cholinesterase inhibitors, like reversible, irreversible, then carbamates, non-carbamates as reversible, then irreversible as organophosphorus compounds and some related compounds related to organophosphorus compounds. Then we understood the concept of aging. So what we are doing right now, we are talking about the pharmacological properties of cholinesterase inhibitors. Cholinesterase inhibitors will eventually act as directly acting cholinomimetics. They are indirectly acting, but their effect will be acting indirectly as excess cholinergic stimulation. Now, among reversible anticholinesterases, only physostigmine is tertiary amine and can cross blood-brain barrier, while all the others, physostigmine, neostigmine, pyridostigmine, ambinonium, we've understood these names. These are carbamate reversible cholinesterase inhibitors. Among them, only physostigmine is tertiary amine. Rest of them are quaternary amine. Tertiary amine means this is lipid soluble, can cross blood-brain barrier, while quaternary compounds act preferentially on the neuromuscular junctions of the skeletal muscles. They cannot cross blood-brain barrier. Then you have rivastigmine, donepezil, galantamine are cerebroactive reversible anticholinesterase. All organophosphorus compounds except ecothiophate are highly lipid soluble. I told you that ecothiophate can slowly dissociate also, and it is to some extent reversible binding, and it is also polar. But all the other organophosphorus compounds are highly lipid soluble. On the contrary, all the reversible cholinesterase inhibitors are polar other than physostigmine, which is non-polar and can cross blood-brain barrier. Now, this was about their polarity and about their distribution. Now, we'll be talking about their action at the neuromuscular junction. So they can decompose physostigmine. Then you have neostigmine and pyridostigmine. These are synthetic. Quaternary ammonium compounds, these are polar compounds. They have got, of course, action will be different. Oral absorption, CNS action is not present, and therefore their action is predominantly on skeletal muscle. And they are also destroyed by plasma excavation. Now talking about you talk about the pharmacokinetics of the reversible anticholinesterases. Now we talk about irreversible. Organophosphorus anticholinesterases are highly lipid soluble. They are toxic mainly used as insecticides and they are made with the toxicity because of the available. They can be used as used to cause homicide, suicide, or possible accidental causes. The less volatile agents are dispersed as aerosols and thus fine particles are absorbed by the skin and mucous membrane and by lungs after inhalation and GIT after ingestion. So these organophosphorus compounds, they can enter the body either through aerosols or they can be ingested. People can drink pesticides. They are hydrolyzed by two types of enzymes known as carboxyl esterases and peroxygenases. Carboxyl esterases and peroxygenases. I have told you there are some plasma esterases which can decompose the reversible anticholinesterases and the organophosphorus compounds can be decomposed by carboxylesterases and peroxygenases. Now, therapeutic uses of anticholinesterases. They can be used in myasthenia gravis. We will talk about what is myasthenia gravis. Then there is reversible of paralysis of competitive neuromuscular blocking agents. We will read this in skeletal muscle relaxants, which will be taken as a subsequent lecture in under the head of peripheral nervous system, PNS. So there is reversible of paralysis of competitive neuromuscular blocking agents used in myasthenia gravis, used in glaucoma. They are also used for the atony of smooth muscle of intestinal tract or urinary bladder, and of course in the treatment of Alzheimer's disease. So these are the uses of cholinesterase inhibitors. Now for paralytic ileus and atony of the urinary bladder, neostigmine is preferred. Neostigmine is used for the relief of abdominal distension and acute pseudo-obstruction. Neostigmine can be used as neostigmine methyl sulfate 0.5 milligrams subcutaneously. It can act in 15 to 30 minutes, or neostigmine bromide 15 to 30 milligrams orally. That will take longer, 2 to 4 hours. It has got poor oral absorption as it is a polar compound. It is used for relief of atony of intestine or bladder. We know this action through our knowledge of directly acting cholinomimetic drugs like betanicol also. Carbocol we studied last time. It is also used for the similar purpose. Now, these agents should not be used when intestine or bladder is obstructed. I told you last time also, they should not be used when there is a mechanical cause of obstruction or whenever there is inflammation or infection. So, these agents to relieve atony should not be used in the case of a mechanical obstruction, infection or inflammation. Now they are used in the treatment of glaucoma. We will probably also have a separate session on the management of glaucoma. But here we will only touch upon the use of these indirectly acting cholinomimetics in the management of glaucoma. So they are used in chronic simple glaucoma. Secondary glaucoma as following cataract extraction. But they are not indicated in congenital glaucoma, and these are reserved drugs as they cause transient blurring, limited visual acuity, and loss of vision at high margins. So they can be used for glaucoma, but we have other preferred drugs for the management of glaucoma, which we will be talking subsequently when we deal with individually with the management of glaucoma. Epothiopate can cause cataract formation also. So you understand that they can be used in the intestinal bladder atony. Other uses could be myasthenia limited to extraocular or eyelid muscles, accommodated convergent trabecular squamous pupil, and you can alternate them with mydriatic for the treatment of infection. Meiotic mydriatic alternates, they can create the synesthesia in the iris and the cornea. Iridocyclitis, it can be helpful. Now let's talk about its use in the treatment of myasthenia gravis. What is myasthenia gravis? Myasthenia gravis, acquired autoimmune disorder that causes skeletal muscle fatigability and weakness. It is associated with the production of IgG antibodies that bind to acetylcholine receptors at the post-junctional motor end plate. What is happening in myasthenia gravis? Myasthenia gravis, there is antibodies which are formed that bind to the acetylcholine receptors, NM receptors, no? At the neuromuscular junction, NM receptors. You have antibodies to the binding sites of acetylcholine at the NM junction, and therefore eventually acetylcholine will not be able to proper action. So what happens in myasthenia gravis is cholinergic deficiency, and you have cholinergic excess in organophosphorus. Anti-acetylcholine receptor antibody titer is raised in 90% of the patients. Now, reduction in the NM receptors reduce the amplitude of the end plate potential and fail to trigger the action potential. So, there is a cholinergic deficiency which is happening. Now, what are the symptoms? Now, symptoms of but I think I am using a perfect internet here. When the Vivek had put up this question, my audio is not clear. I would want to know whether this problem has been addressed too or not. Okay. Am I audible? Is it okay? Are you understanding? So I understand there has been some issues in between. So now it's okay. So I can continue. Fine. You can discuss with me after I finish the class if you have any issues. Okay. So I move on to the myasthenic condition wherein there is cholinergic deficiency. And how does it how does it appear? There is a weakness of muscle and fatigue that worsen after exercise. Early stages, the fast moving muscles are affected, and the response is like diplopia, ptosis, slurring of speech. So there is cholinergic deficiency, because of which there is difficulty in swallowing and weakness. Progressively involves all muscles, including respiratory muscles. Now, diagnosis of myasthenia gravis can be by doing the anti-acetylcholine receptor antibody titer. There could be a repetitive nerve stimulation test. Repetitive stimulation of the muscle with the electrical impulses can measure the fatigability of the muscle. But most common is the electromyography, is considered to be the most sensitive test for myasthenia gravis. Now, there used to be this Edrophonium test. To diagnose myasthenia gravis if antibody titer is not available or is negative. To differentiate between muscular paralysis caused by myasthenia gravis and by cholinergic crisis. Cholinergic crisis at the motor end plate would lead to persistent depolarization and no polarization, no repolarization. And muscle will be relaxed later on, So what is edrophonium, ambinonium? These are, the drugs which increase the cholinergic stimulation. So when 1 to 2 milligram IV test dose of edrophonium is given, if the muscle weakness worsens, then there is a cholinergic crisis. And if there is no cholinergic side effects, further 5 to 8 milligrams of this can be given, then there is improvement in the strength of the muscle. But this is really not needed. You really don't need to know much about it. All we would be needing right now is why is myasthenia gravis caused and how do you treat it? Treatment of myasthenia gravis can happen with neostigmine because it is a polar anticholinesterases. It is given as 15 to 30 milligram IV 6 hourly. Or pyridostigmine or ambinonium, any of these can be given. They will act by increasing the cholinergic strength. The dose required may vary from day to day according to the response, and regular monitoring of the patient has to be done. Now, when you do this, muscarinic, cardiovascular and gastrointestinal side effects can happen. And they can, if they happen, then they will have to be treated with the anticholinergic drugs. So in general, if somebody asks you, myasthenia gravis is a condition that happens because of depletion of the cholinergic receptors. It's an autoimmune disease, so there will be a cholinergic deficiency. So something which will need to be given is the anticholinesterases. They will improve the weakness and they will improve the strength, and they will have to be given repetitively. And they by themselves can cause cholinergic excess, and for that, sometimes you might have to give anticholinergic drugs for its treatment. Other therapeutic measures can be glucocorticoids, immunosuppressants, thymectomy, and plasma therapy. Now, another use of these drugs could be post-operative decurarization and treatment of curare polygyny. This, as I told you, will be taught to you in the peripheral nervous system. Neostigmine again or edrophonium can be given along with atropine that rapidly reverses the muscle paralysis induced by competitive neuromuscular blocking agents. I'm not going to spend much time on it. This will be dealt with in details later. Then you have a very important condition by the name of Alzheimer's disease, for which we really do not know the pathophysiology much, but it is seen that the cholinomimetic drugs use benefit in the management of Alzheimer's disease. You can give tacrine. These are non-carbamate reversible cholinesterase inhibitors. Non-carbamate reversible cholinesterase inhibitors include tacrine, donepezil, rivastigmine, and galantamine. You could in general be given asked management of Alzheimer's disease, and there could be other agents also. You have to talk about these cholinomimetic drugs there. Now, intoxication by anticholinergic drugs. In addition to atropine and other muscarinic agents, many other drugs such as phenothiazines, antihistamines, tricyclic antidepressants have central and peripheral anticholinergic activity. Physostigmine is potentially useful in reversing the central anticholinergic syndrome produced by the overdose or unusual reaction to these drugs. So you can use these cholinomimetic drugs also in the management of poisoning by the anticholinergic drugs. There could be direct anticholinergic drugs like atropine, which we will be reading in the subsequent classes, or there could be other drugs with additional anticholinergic properties like phenothiazines, antihistamines, antidepressants, whose excess can be managed by cholinesterase inhibitors. These drugs we will be reading subsequently in our classes on autocoils or central nervous system drugs. Therapeutic uses of irreversible anticholinesterase inhibitors. There are hardly any therapeutic uses for this group. Ecothiopate can be used topically as it is reversible also to some extent as a meiotic for the treatment of glaucoma. Carbaryl for the head lice. Diisofluorophosphate, occasionally used as meiotic, but these hardly any uses of these drugs, So just for academic interest, I'm talking about their uses. Otherwise, these irreversible anticholinesterases are generally used as pesticides or insecticides. And generally, we are dealing with their poisonings only. So now let's come to the last topic for the day. Anticholinesterase agents, their toxicity. Their toxicity will of course be cholinergic toxicity only now. Acute intoxication manifested by muscarinic and nicotinic symptoms. Their intensity depends upon lipid solubility. The more is the lipid solubility, more is the intensity of the toxicity. Systemic effects appear within minutes after inhalation of vapors or aerosols. They can be delayed in the gastrointestinal if they are taken by gastrointestinal or percutaneous route. The faster is the route of administration like vapors or aerosol, lipid solubility will lead to excessive nausea or excessive poisoning. Well, if they're taken by percutaneous route or by GI route, the development of toxicity will be little slow. Inhalational, ocular or respiratory symptoms will appear first. By ingestion, you will have gastrointestinal symptoms like nausea, vomiting. Percutaneous routes, you will have sweating, muscle fasciculation. Severe intoxication, there will be extreme salivation, involuntary defecation, urination, sweating, lacrimation, hypotension and bradycardia. All these are the symptoms of excessive cholinergic stimulation. So you know by the route of administration, you can understand what all will be affected in the body. Inhalational, you have respiratory symptoms. Ingestion, GI symptoms. Percutaneous, you have stretching and fasciculation. Severe intoxication, you have extreme cholinergic stimulation. You have to just remember what cholinergic stimulation does, and I'm sure you can make out what all will happen in its toxicity. Now, nicotinic action, there will be fatigability, fasciculation. CNS, there will be confusion, ataxia, slurred speech, loss of reflexes. Time of death may be 5 minutes to 24 hours depending upon the dose. Delayed symptoms may appear after 1 to 4 days as severe muscle weakness. This is the intermediate syndrome. Acute delayed neurotoxicity in the form of polyneuropathy may appear with organophosphorus compounds. So the toxicity symptoms will depend upon the route and the dose of administration. If the route is inhalational, it will be very fast. If it is oral, it will be little slow. There could be acute symptoms like confusion, slurred speech, loss of reflexes, or there could be delayed symptoms like which might appear after 1 to 4 days, or there could be delayed neurotoxicity. So all these symptoms will depend upon the nature of the agent and its route of administration and its dose. Treatment of organophosphorus poisoning. General measures have to be taken immediately. You have to remove the patient from the site of exposure, terminate the exposure, maintain airways, oxygen, artificial respiration if required, alleviation of persistent convulsions with diazepam, and treatment of shock. So all these are symptomatic measures. You don't have to immediately look for, antidote. First thing is airway, oxygen, artificial respiration, manage convulsions if they are happening by diazepam, and treat shock. All these symptomatic benefits have to be provided to the patient. Remove the exposure, wash the hands, wash face, and institute good oxygen supply. Atropine is given in sufficient doses to cross blood-brain barrier. See, if you do not have an antidote, you could give atropine because there is cholinergic excess. 2 milligrams IV has to be given every 5 to 10 minutes till the sign of muscarinic symptoms disappear and sign of atropine toxicity appears. All this has to be judged by measuring the size of the pupil, because atropine might have to be administered very frequently. Then you have cholinesterase activators. I told you they are cholinesterase activators. Pralidoxime, 1 to 2 grams pralidoxime given slow IV infusion over 15 to 30 minutes. In case of organophosphorus poisoning, the only important thing is the time. The faster you start the therapy, the better it is. Otherwise, you will have aging of the cholinesterases and loss of alkyl groups, and then it will be very, very difficult to reverse the toxicity. Now, reactivation of phosphorylated acetylcholinesterases. As I told you, oximes, pralidoxime is one of them, used to reactivate phosphorylated cholinesterases. This group has got high affinity for phosphorus atom, NOH. Pralidoxime has a nucleophilic site that interacts with the anionic site on the phosphorylated acetylcholinesterase. The other oximes could be diacetyl monooxime, DAM. PAM and DAM are important ones which have to be used in the organophosphorus poisoning. Now, limitations of pralidoxime. Pralidoxime will not interact with the carbamylated acetylcholinesterases. Pralidoxime in high doses can inhibit acetylcholinesterase also. Quaternary ammonium compound does not cross blood-brain barrier. Aging of the phosphorylated acetylcholine enzyme reduces the effectiveness of pralidoxime and oxime reactivators. What is this slide showing us? Slide is showing us that the pralidoxime on oximes will have limited utility and they will have to be instituted very fast. Carbamylated acetylcholinesterase will have no benefit of pralidoxime. Pralidoxime can only be helpful in the phosphorylated acetylcholinesterase and will have to be given fast. It will have not much role in the CNS involvement because it will not cross blood-brain barrier. So I hope you understand this, and with this we finish with our class on these indirectly acting cholinomimetic agents. Now back to you students. So I'm told that my audio became okay a little bit. See, use in glaucoma, we will be talking about it little later also. Vivek has asked this question. In glaucoma, see, I told you last time that pilocarpine is being used because it is going to be a meiotic and will also help in realignment of the trabecular meshwork. So the same action will be done by these indirectly acting cholinomimetic drugs, and they also will produce action similar to pilocarpine. Therefore, they are used in the management of glaucoma.